This conference will now be recorded.
All right, perfect. All right, so just so everyone knows about the Great Plains Colorectal Cancer Task Force, some of you already are aware, but the subaward will participate in the Great Plains Colorectal Cancer Task Force. The Great Plains Colorectal Cancer Task Force meets quarterly, which is 4 times a year via webinar. The goals are to engage communities and foster partnerships that will allow organizations and individuals to establish collaborative approach to increase colorectal cancer screening among Northern Plains American Indians by providing education, outreach, and the Great Plains Colorectal Task Force will strengthen the community resources and community clinical linkages. So this task force prioritizes health behaviors and lifestyles to improve and enhance quality of life, as well as reduce the risk factors associated with chronic disease. So the Great Plains Colorectal Cancer Task Force provides a forum of input, advocacy, education, collaboration, planning, and action along the cancer control and chronic disease continuum. There we are. Okay, so just what we'll be going over today on the agenda is the no cost extension, the final report, the Great Plains Colorectal Cancer Screening Initiative 5-year grant, CRC screening during COVID-19, the March recap, areas of impact, and then kickstarting CRC screenings along with Cologuard, and lastly finishing off with ACID Inc. Okay, so our no cost extension was submitted to our funder from the Center of Disease Control early June and has been approved. So the no cost extension funds was requested to complete year 5 closeout activities that were delayed due to COVID-19 pandemic. Many tribal facilities within the Great Plains region have been affected by the current pandemic, which led to the majority of facilities putting CRC screening to the side and bringing care of current patients dealing with and preventing COVID-19 to the forefront. Previously, all activities and implementations were due on June 30th, 2020. And since the approval of our no cost extension, all activities implementations have been pushed back to December 31st, 2020. So what this means is that all activities and screenings initiatives that have been extended. So the closeout activities would include sustainability planning, subaward evaluation, and sustainability, providing education and assistance to partners facilities, development of sustainability plans, Zoom conference calls to provide technical assistance in developing sustainability plans, data collection. So year 5 evaluation report summarizing all data collected in the year 5. Key informant interviews, evaluation, convening partners and facilities and bringing partners and facilities together to discuss lessons learned and sustainability plans, supporting subaward CRC screening, and that would include all of the screening factors along with that are associated with colorectal cancer. All right. So final reports. So what does this mean with the final report? So GPCCSI does have to go through a process of collecting all reporting documents for from our funders, or to our funders, and the Center for Disease Control, which would take about a month of getting necessary documents, which is why we, the Great Plains Colorectal Cancer Task Force, would need all final reports and sustainability plans submitted by November 30th, 2020 from all subawards within the Great Plains region. So if you have a Colorectal Cancer Screening Subaward with the Great Plains Colorectal Cancer Screening Initiative. That means that you would have to send those in by November 30th, 2020. The final report is a 5-page document that must be completed entirely to submit. So for those who have submitted a no-cost extension, you'll pick up where you left off on the application, where it says stop here requesting for no-cost extension. You'll pick up from there and finish the final 4 pages. Along with the final report, we are kindly asking that each facility attach a sustainability plan as well. Since Great Plains Colorectal Cancer Screening Initiative is in the 5 and final year of the CRC grant, we created a sustainability plan per program for our facility to sustain CRC efforts and screening in the document that was provided. Each designated navigator tailored a sustainability plan specifically to each facility. So if you haven't got one, just reach out to us and we'll get those to you. Should there be any questions, just feel to reach out to your designated navigator for assistance, which would be me or Gina. All right, so what does this mean now? Which brings to this point. With all that being said, we regret to inform you that there will not be a continuation of another 5-year CRC grant for the Great Plains Colorectal Cancer Screening Initiative. GPCCSI does understand that the RFP for the grant is extremely competitive and that the chances of another award for the grant could be denied. So we, the Great Plains Colorectal Cancer Screening Initiatives, have worked continuously on the grant application, working with tribal communities on letters of support, whether that's from tribal health directors, CHRs, or other personnel, as well as trying to extend outreach and efforts beyond the Great Plains region. And for that, we, the GPCCSA team, are extremely grateful for all of the hard work that has been put into this grant application. We also wanted to thank each one of the tribal communities that utilized the funding from the grant cycle to increase the screening rates of colorectal cancer screening and lowering the high mortality and incidence rates among American Indians in the Great Plains region. Excuse me. We couldn't be any happier with all the events and activities that were carried out through year 5, or well, basically throughout the whole 5-year program, and we are extremely blessed to be a part of it and welcomed into the community. So with that, we thank you. And let's see here. All right. So CRC screening during COVID-19. So the total number of colonoscopies and biopsies performed declined nearly 90% by mid-April compared to the same period last year. Colonoscopy screening and biopsies declined sharply following shelter-in-place orders. Colonoscopy rates were stable over the first 11 weeks of 2020 prior to the first shelter-in-place order that began in California on March 19th. During the week of March 16th through the 12th, colonoscopies fell 42%, and by April 12th, colonoscopies had fallen by 89%. In line with screening declined, biopsy rates also declined by 88.8 by mid-April. Colon cancer diagnosis declined while treatment plummeted. So new colon cancer diagnoses were more than 32% by mid-April. More surprising, through the colorectal cancer surgeries fell by 53% in the same time period. Some of this decline in treatment can be explained by the drop of diagnosis, but the steep drop off in the surgery suggested a more dire situation in which patients newly diagnosed with colon cancer in the preceding months have had their surgeries postponed. This delay in surgery could be resulted in the progression of the disease and vulnerable populations. In many cases, as shelter-in-place orders continue for much of the country, and as fear of infection persists, those delays could continue in the foreseeable future. So nearly 40% of colorectal cancer patients and caregivers reported disruptions in their care, especially as it relates to in-person visits and imaging. Of these, 25% said that they did not know that their care would be rescheduled, and 34% said that their visits changed to telehealth. Colorectal cancer patients experience fear, frustration amid the pandemic in navigating day-to-day activities as well as healthcare interactions. 63% of colorectal cancer patients reported that they are concerned about contracting COVID-19 for the health of their families. 51% reported general concerns for the future, and 45% said that they are concerned about the government leadership, while 21% reported concerns about finances and 19% reported feeling isolated. Overall, the majority responded feel nervous, anxious, on edge, and 50% said that they can't stop worrying. So colorectal cancer patients want safety measures in healthcare facilities and in the communities. So focus groups participants mentioned changes in the experiences in their care, such as safety measures implemented at their cancer centers. This includes personal protection equipment for healthcare workers, removal of brochures and chairs in waiting rooms, and the reduction in company joining patients for appointments. While these measures negatively impacted the human side of cancer, they are also reassuring patients that their provider were taking the necessary precautions to keep them safe, especially in the infusion rooms. On focus, participants remarked that during her infusion appointment, said that I felt at this very moment, sitting here at the chemo, I'm in the safest place I can be, safer than walking around a bunch of people. All right. And then this is just a recap of the National Colorectal Cancer Awareness Month during COVID-19 pandemic. As you can see, on March 13th, 2020, the United States national emergency was declared due to COVID-19. On March 14th, 2020, Surgeon General advised hospitals to postpone all elective surgeries. March 15th, 2020, it was recommended by the GO Endoscopy and Clinical Practices strongly consider rescheduling elective non-urgent endoscopic procedures. And then sometime in mid-March, it was announced that from the American Cancer Society, no one should go to healthcare facilities for routine cancer screening until further notification. And with the ongoing pandemic, health professionals realized that the areas of impact would be the minority population. So this includes the American Indian, Alaskan Native, the African Americans, and Hispanics. In the Great Plains region, our reservations would be the ones who would be most vulnerable because the majority of reservations are more rural and spread out. This would be a problem, and as it always has been, an issue in the past in regards to colorectal cancer screening. Because a lot of CRC patients fall under the ages of 50 to 75, this means a lot of patients lack digital literacy. And this would be a challenge due to a lot of healthcare facilities utilizing telehealth as a means of digital contact during the COVID-19 pandemic. And of course, our high priority patients considering all the variables. This includes patients with prior and current abnormal stool-based samples, patients with family history, patients over 50, and patients with genetic health factors and abnormalities. All right, so kickstarting the CRC screening. And this is where we kind of bring into play with sustainability as well. So reassuring patients and community members of the safety measures set in place at healthcare facilities during the current pandemic. Like previously mentioned, a lot of people that do go into their procedures or their scheduled appointments, they do feel safe in facilities because a lot of the facilities are taking the necessary precautions and guidelines with CDC, the American Cancer Society, and other organizations that help during this current pandemic. And they're taking all those types of considerations into play as they screen and test other patients. So there's no fear, and that's one of the things that we would want our patients and community members to realize is the safety measures that are set in place in our healthcare facilities. Prioritizing high-risk patients for colonoscopies, and this would be the ones that fall under the age range, as well as those with family history, those who tested positive on a stool-based sample, or those with any type of abnormalities or genetic factors. Also, another thing would be to extend the CRC awareness year-round, and this is something that the American Cancer Society has mentioned. So we are encouraging that all subawards, people that are implementing CRC awareness, to just go ahead and extend it year-round. Mail-in screening opportunities. So this is something that would be new to a lot of facilities. The mail-in screening opportunities would include the fecal occult immunochemical testing. Sorry, that's a mouthful. The fecal occult blood testing, as well as the stool DNA. And we do have guest presenters that will be talking more on the stool-based DNA testing here shortly. And those are the people from Exact Science. So let me see here. I only got one more thing that we'd want to talk about. So the mail-in stool testing, patients who are at average risk, and this would be just people coming in for routine screening as well. Utilizing and surrounding sources of healthcare facilities, tribal fundings for resources, and this would include postage or anything with the mail-in screening. Reallocation of remaining subaward budget. So all of our subawards have a set budget. If you need any type of, if you have remaining funds, if you would like to move some things around, just let us know and we can assist with that. And you can use those funds for any type of postage or anything in regards to mail-in stool testing. This is something that GPCCSI would want to be able to assist with. So we do have funds available for postage. If you are out of funds or don't have enough, reach out to your designated navigator and we'll be glad to assist you. So requests can be made through your designated navigator, which would be either me or Gina Johnson. And now I'll go ahead and turn it over to our guest speakers from Exact Science.
Thanks, Eugene. This is Greg Starcher with Exact Science. Are you able to hear me well?
Yes, we can hear you.
Awesome. Well, I wanted to first thank you for allowing us to be a part of your meeting. It looks like you have some challenges ahead of you, as we all do, with respect to COVID. But with challenges, we find better ways of doing things. So again, I wanted to thank you for having us here so that we can speak to you about Cologuard. Earlier, I had a conversation with some of the clinicians, and they, in our conversation, there were three basic, issues or challenges that they were trying to overcome, and that was one was limitation of access to colonoscopies. That we had some discussions around patients, and I think your survey data showed that they were that colonoscopies dropped off because patients following the federal guidelines weren't going to get elective screenings. The second issue was access to multiple visits, I guess, doing their fit testing at the local clinic. The patients would have to come in, get the test, and then return with the sample back to the clinic. And so that multiple visit was an issue for the clinician and for the patient having to travel from their location into the facility. And then the third challenge was just staff time utilization. There are so many things that the staff is having to do with the COVID-19 prep and protection for their patient safety, that following up on these tests that are going out into the community, getting them back in is just more time consuming with the additional steps that they're taking. So those are the three issues that were discussed, and then so in relation to those, we wanted to put together about a 10-slide presentation, so it'll be quick. We'll go through the indications and the contraindications, and then we'll go through some of the highlights and how Cologuard and Exact Science can address some of these challenges. And then we'll have time for questions. If that works for you, we can proceed to the next slide. So Cologuard, I'm going to read this to you so that we make sure that we're in. You can read it as well. But Cologuard is intended for a qualitative detection of colorectal neoplasia associated with DNA markers and for the presence of occult hemoglobin in human stool. A positive results may indicate in the presence of colorectal cancer or advanced adenoma and should be followed up with a diagnostic colonoscopy. Cologuard is indicated to screen adults of either sex, 45 years or older, who are at typical risk, average risk for colorectal cancer. Cologuard is not a replacement for diagnostic colonoscopy or survey colonoscopy in high-risk individuals. Cologuard is not for high-risk individuals, including those with a history of colorectal cancer or advanced adenoma, a family history of colorectal cancer, IBD, or certain hereditary syndromes. Positive Cologuard results should be referred to diagnostic colonoscopy. A negative Cologuard test results does not guarantee absence of cancer or advanced adenoma. Following a negative result, patients should continue participating in a screening program at an interval and with a method appropriate for the individual patient. Cologuard's performance when used for repeat testing has not been evaluated or established, RX only. So that's the indication. Some of the highlights that I wanted to just bring out again is the fact that Cologuard is indicated for either sex, age 45 years or older, and who are at typical average risk for colorectal cancer. You will find that the USPSTF still has colorectal cancer screening for at age 50. So there are two separate schools of thought, but currently the USPSTF is at age 50. However, Cologuard has been indicated for those patients down to age 45. All right. So the contraindications. Cologuard is intended for use with patients age 45 years and older at average risk who are typical candidates for colorectal cancer screening. Cologuard is not clinically evaluated for the following types of patients: patients with a history of colorectal cancer, adenomas, or other related cancers, patients who have a positive results from another colorectal cancer screening method within the last 6 months, patients who have been diagnosed with a condition that is associated with high risk for colorectal cancer, and finally, patients who have been diagnosed with a relevant family hereditary cancer syndrome. So that concludes just the contraindications and indications. Again, what we want to highlight is for patients that are at high risk, Cologuard is not appropriate for those patients. Patients that have had a positive result with in terms of cancer with FIT or with colonoscopy, again, those are patients that are at high risk. Cologuard is only for those patients of average risk. Cologuard warning and precautions. This is the last slide I'll read verbatim to you all. The performance of Cologuard has been established in cross-sectional studies, single point in time, programmatic performance of Cologuard, benefits and risks with repeated testing over an established period of time has not been studied. Performance has not been evaluated in adults who have been previously tested with Cologuard. Non-inferiority or superiority of Cologuard programmatic sensitivity as compared to other recommended screening methods for colorectal cancer or advanced adenomas have not been established. The clinical validation study was conducted in patients 50 years of age or older. ACS guidelines recommend screening begin at age 45. Cologuard performance in patients ages 45 to 49 years was estimated by subgroup analysis of near age groups. Colorectal cancer screening guidelines recommended vary for persons over the age of 75. The decision to screen persons over the age of 75 should be made with the individual basis and consultation with the healthcare provider. Cologuard test results should be interpreted with caution in older patients as the rate of false positive results will increase with age. A negative Cologuard test results does not guarantee absence of cancer or advanced adenoma. Patients with negative Cologuard test results should be advised to continue participating in a colorectal cancer screening program with another recommended screening method. The screening interval for this follow-up has not been established. So again, the highlights off this one is that really your survey talked about having to continue screening process, not just in the month of March, but for the remainder of the year. This moves right along with those recommendations that your survey brought out, that each of these clinics should continue to promote colorectal cancer screening. Anyways, Cologuard may produce false negative or false positive results. A false positive result occurs when Cologuard produces a positive result, even though a colonoscopy will not find cancer or precancerous polyps. A false negative result occurs when Cologuard does not detect a precancerous polyp or colorectal cancer, even when a colonoscopy identifies the positive result. Patients should not provide a sample for Cologuard if they have diarrhea or if they have blood in their urine or stools from bleeding hemorrhoids, bleeding cuts or wounds on their hands, rectal bleeding, or menstruation. To ensure the integrity of samples, the laboratory must receive the patient's specimen within 72 hours of collection. Patients should send stool samples to the laboratory according to the instructions stated in the Cologuard patient guide. Patients should be advised of the cautions listed in Cologuard patient guide. Patients should not drink the preservative liquid. The risks related to using Cologuard collection kit are low, with no serious adverse events reported among people in the clinical trial. Patients should be careful when opening and closing the lid to avoid the risk of hand strain. So that ends the colorectal warning, or Cologuard warning and precaution slide. So we talked a little bit about earlier, on the screen you'll see 6 different boxes, and those are the 6 screening options for colorectal cancer. The first 3 on the left are non-invasive options. So you have the GUIAC cards, the FIT card, and what it says there is multi-target stool DNA, MT-stool DNA. That is Cologuard. Then you have FlexSig, CT, and colonoscopy. Underneath each one of those boxes, it tells you the requirements in terms of how often they should be repeated. So if you look at both the GUIAC cards and FIT, they need to be repeated every year. And then if you look at Cologuard, which is the multi-target stool DNA in the middle, that's every 3 years. And then FlexSig and CT are every 5, and colonoscopies every 10 years. So one of the things that we talked about earlier was that there's a limitation to access of colonoscopy. I believe there's only 1 or 2 facilities that actually have GIs or folks that will do a colonoscopy. And so there's a limited access for the patients. And so one of the ways that we can help, and that is that we can do a screening test with Cologuard. So the patient will get a screening test that allows them to only have to do it every 3 years when they have a negative results. So they do not have to repeat it every year. And so when you have access issues, Cologuard will help in terms of the time frame that a repeat negative tests, where you have a fit test and the patient has to go access the facility, I believe, get a test, go home, complete the test, and then bring it back into the facility. Again, what we're trying to do is eliminate some of those issues with the patients having to travel back and forth to these clinics. If you go to the next slide. This is basically a simple, it gives a presentation. So what you see there is like a colon that's been cut in half, and then it talks about the stages of cancer from pre-cancer to stage 4, and it really is what makes us different from the other 2 non-invasive tests, and that is as stool is moving through the colon, it is collecting the cells that are sloughing off the lumen, and then Cologuard does a test on those 11 different biomarkers, looking at those cells to determine if that patient's cell count or the algorithm basically states is this patient probability of having cancer or not, and then you have a positive or a negative test. The difference is that Cologuard looks at both altered DNA and blood, whereas the FIT test, the other non-invasive tests, look at just blood. And that's generally how it works. You may have further questions about the testing and the process, and we can get answers to any of those questions that you might have. Next slide. So in the first couple of slides, we talked about our head-to-head trial. There were roughly 10,000 patients, ages 50 to 84, with average risk of colorectal cancer. They were screened both head-to-head with Cologuard and FIT, and then they looked at the end of the trial. The results were basically looking at both sensitivity and specificity. If I can't say that word, specificity of Cologuard versus FIT. And what you have in this particular slide is you have the early stages, so stages 1 and 2. Obviously, the earlier we can catch cancer, the more able we are able to treat cancers and heal that patient. And what you'll see in these slides is in the early stages you had sensitivity of 92.3 for Cologuard and 73.8% for FIT. And then again, that's overall. And then within the early stages, so that's overall. And in the early stages, you have 94% sensitivity versus a 70% sensitivity. So if you look, not that you can see it very well, but there are some data below that basically takes a look at overall specificity. And just to make sure that we're clear, so the specificity of the two, if I can recall, is I'm blanking. I'll come back to that, and I'll get you the specificity on Cologuard as well. So if you go to the next slide. This is basically taking a look at the patient's compliance at both 1 year and 3 year. So what we're wanting to address here is those patients that are coming in for FIT, they have to come in and get their test, complete their test, and then the following year they have to do the exact same process, complete their FIT test, and then the next year, the third year, they have to complete the fit test. What it shows is that at the year 3, your compliance rate for fit screening is 14%. Cologuard within the first year of prescribing is 88% compliance, which means you have that patient 88% of the time will complete the test in year 1, and then they don't have to complete the test if they're negative for 3 more years. So when looking, comparing the two, Cologuard's 88% compliant screening at year 1, and FIT is compliant 14% of the time over a 3-year period. Next slide. So we addressed in the beginning, we talked about the staff's time and what does Exact Science and Cologuard do to help with the staff's time utilization. The picture to the right is a picture of 5 circles within a circle. And the first circle that you see in the right is a welcome call. Once a patient has been ordered Cologuard, we will I'll pick this up quite a bit. So you have a welcome call from Exact Sciences. The kit will be sent to the patient. There'll be a reminder call if the patient does not. So again, taking that burden off the staff. And then there'll be another reminder call if they still have not returned the kit to our lab. The way the kit is returned is that the kit is picked up by UPS and delivered back to our lab, and then the results are sent directly to the clinic. So that is the way that we are able to reduce the burden on the staff. We do have a 24 hours to 7-day support line. Again, it is home delivery. We have worked within rural communities all over America. We have developed plans to make sure that these kits are delivered and then also the results returned back to the lab. Next slide. This is our mantra: get, go, gone. It's that simple for your patients. And then we get the tests back to the facility, or the results back to the facility, so that they can let the patient know how they're doing and what their next steps are, either being an additional screening 3 years from now, or if they need to have a colonoscopy. Next slide. So basically, here's the information about sensitivity. We've talked about that. We've talked about the built-in compliance program, which there's a lot that goes into that. The local representative there, Jackie, will be able to explain that to you in detail. It is at home test, and that the results come from them to us and back to your clinics. And then finally, you have the UPSTF and ACS guidelines. So the HEDIS metrics, 3 years credit, 3 years to have to do the test over again. And then the final slide, I think, is just a little bit about the local market. In terms of the federal market, it's covered 100% by Medicare, 100% by TRICARE. And then Jackie, I believe, can speak a little bit about the local state availability.
Yeah. Hello, can you hear me? This is Jackie with Exact Sciences. Making sure that I am off mute. Thank you so much, Greg. You did a great job of going through the slides and covering all the things that we have talked about. In talking with Eugene and Tinka, we talked about coverage, of course. Just an update, the federal supply schedule with Exact Sciences, we do not have that contract yet. It is forthcoming and in process of getting that approved and in line. For our Medicaid coverage, For South Dakota, that is a strong yes. It is covered under Medicaid. We are very close in Iowa and North Dakota for having the Medicare coverage. But however, in Nebraska, that was recently declined as well. So we're not going to have the Medicare coverage, Medicaid coverage in Nebraska. As Greg mentioned, yes, we have, of course, the Medicare Advantage coverage is there along with TRICARE and these other commercial contracts. So I know that's going to be kind of an area by area opportunity as to coverage with some of these different payers. But in finale, that covers the presentation that we had for you all today. And I would like to open it up for questions. If anybody may have any questions, and if you're shy and you want to reach out to me, I also can provide my direct line information too, if anybody would like to email or call me.
Hey, Jackie, this is Eugene Gallego. We're almost close to the end of our presentation, and we'll go ahead and open up the questions till after the presentation, which is in a couple more slides. So just here in a little bit.
Thank you.
Yep, thank you. All right, so moving forward, we have our newest member of the Asset Inc. team, which is Rachel Inc. She'll be introducing herself and kind of going over the 30-minute interviews that will be set up for subwards who have completed their CRC projects. So Rachel, if you would want to chime in.
Sure. Thank you, Eugene. Hello, everybody. As Eugene mentioned, I'm Rachel Eng. I'm a research associate at Asset, and I believe my colleague Stella C1 Zimmerman is also on the call. And so I just wanted to introduce myself. I'm new to Asset and this project, and I'm really excited to talk with you all after you complete your projects. So I will be reaching out to you via email shortly after you hand in your final progress report, and then I'll just schedule a 30-minute conversation with you to talk about what happened over the last year, what went well, what was hard, what you learned, and then plans for sustaining your work. So just as you complete your work and turn in your final report, just look for an email from me to set up that 30-minute phone call. So thank you.
Awesome, thank you, Rachel. And if any subaward has any questions or want to reach out to Rachel, feel free to reach out to me and I can get you in contact with her. Thank you, Rachel. And last, we want to still make this available for all of our partners in the Great Plains region, as well as our subawards, most importantly. So for programs and organizations looking for printable CRC education materials, we have access to these documents on our website. So like during the month of March, we were able to send out new and existing materials for our tribal partners. COVID-19 kind of changed that things a bit, so we would still be able to mail those out though moving forward. So if you'd like access to these documents and have them in your community, you may do so by accessing the link above, or may utilizing these steps to access these materials. So if anyone would have any questions on any of the materials, feel free to reach out to me or your designated navigator. And with that, we want to thank everyone for joining. And also, if you have any questions at this time, now's the time to go ahead and unmute yourself and ask any questions to either me, Tinka, Gina, Asset Inc., and Exact Science.
Hi, this is Gypsy in Sisseton.
Good morning, Gypsy.
Good morning. How much do those Calabar tests cost? I mean,
That would be a question for either Greg or Jackie. Jackie or Greg, did you want to answer that?
So the Medicare cost, I believe, is what is charged, and that's roughly $529. I'll have to look and see if it's been revised here recently, but that's roughly the charge that most federal organization gets. And so the question would be, I guess, if you're using Medicare or TRICARE, then the cost should be nothing for the patient.
okay.
But I can get, if you would like, I can get you the exact newest figures in terms of what the rate is. I don't know what the commercial rate is, and I'm not sure, since we don't have a federal supply schedule, how the patient would be billed within your system.
Okay. Yeah, and so at this facility, you know, it's IHS. We're not a tribally run. We're an IHS facility, and I don't know that we'd even be able to use them, but I just wanted to find out, and you know, costs and all that. So that's all. Thank you.
Thank you, Gypsy. Also,
Hi, can you hear me?
I do want to add that we do have a subaward tribal facility within the Great Plains, well, which in South Dakota, on the far east side in Flandreau, that they are a 638 facility, and they do utilize Cologuard as well as FIT FOBT along with colonoscopies as well, and they do go through Exact Science for their Cologuard. Is there any more questions?
Hey, this is Lindsay in Flandreau. I just wanted to ask Exact Sciences if they had talked about getting us a price for the Cologuard to be able to use and be paid for through PRC for our patients that don't have insurance. And I was just wondering where that conversation was at.
Hi, Lindsay. Yeah, this is Greg Starcher. Yes, so we are still in multiple rounds of discussion around all those customer billing questions and how to go about the service facilities just like yours and the VA for that matter. And it's a slow process, but it is something that is definitely on the front burner. We are looking to make changes in the way that Exact Sciences does contracting. I know the local folks within the northwest part of the United States are actively seeking a voice for that conversation. So I can only tell you is that we're talking about it, and we're trying to make something happen internally to Exact Sciences. And as soon as we get an answer, we'll let you know.
Sounds good. I was just going to say that we've had really good luck utilizing Cologuard with our patients that do have insurance and, meet the qualifications. They have been covered at 100%. So to the gal that's from Houston, if she wants to get a hold of me too, we can talk about what things we've done, because Houston would be able to use it too for their patients that have insurance.
Awesome, thank you, Lindsay. Yeah, Gypsy Wana with Sisseton Wapton Oyate. If you would like, I can forward you some information to Lindsay so that she would be able to assist with that. All right, any more questions?
Eugene, can you hear me?
Yes, I can.
Oh, there's some in the chat.
Oh, give me 1 second.
And now we're over time, so
Here we are. Okay. So is Cologuard covered through North Dakota Medicaid, Medicare? Is one of the questions from up in, I believe it might be 3 affiliated tribes.
Hey, Eugene, it's Jackie. So, of course, Medicare Advantage, Medicare, it is full coverage. In North Dakota, it is on the fee schedule. We are just updating a few credentialing commitments on our end, and so that is going to be very soon forthcoming. Do not expect that to be long at all. So as soon as we get that green light, if it's okay with Eugene, Eugene, I'll just make sure you and Tinka know, and then you can forward that information out to all of your contacts.
Awesome. Thank you so much, Jackie. Yeah, our North Dakota tribes are basically in general with North Dakota, they are under the Medicare Medicaid expansion. So a lot of them would be able to have that access for Cologuard and the coverage as well. So I'll be sure to look out for your email, Jackie, whenever you get the green light, and then I'll go ahead and send the information out to all of our North Dakota tribes so that they'll be able to utilize Cologuard in their facilities. Is there any more questions? If not, we are over the hour by 4 minutes, not bad. All right, I want to thank everyone for joining us, and we look forward to our next time that we meet with everyone else. So thank you.
Thank you, Eugene.
Thank you.